Hello. In this presentation we're going to look at analgesic, anti-inflammatory, antipyretic, and musculoskeletal drugs. Now there are some drugs that fall into more than one of these categories. Some fall into all four categories. So take for example a drug like ibuprofen. It is an analgesic drug. It is an anti-inflammatory drug. It is an antipyretic drug, and it is a musculoskeletal drug. Other drugs, like acetaminophen, may just fall into 2 or 3 of these categories. So this is why we're going to talk about all these drugs in one particular presentation. It's because they often cross over and have common characteristics. So first of all, we're going to look at analgesic, anti-inflammatory, and antipyretic drugs. And this is in pages 64 and 65 of your textbook. So a turning point question would be, an analgesic drug is a drug that 1. Reduces fever, 2. Reduces inflammation, 3. Causes a loss of consciousness and or sensation, 4. Relieves pain, or 5. All of the above. And the answer is number 4, relieves pain. So the definition of an analgesic drug is a drug that relieves pain. An antipyretic drug is a drug that 1. Reduces fever, 2. Reduces inflammation, 3. Causes loss of consciousness and or sensation, 4. Relieves pain, or 5. All of the above. And the answer is number 1, reduces fever. So an antipyretic drug, by definition, is a drug that reduces fever. I always remember that because of the root word pyro, fire, or fever, right? So an anti-fire or anti-fever, antipyretic. That's how you can remember that. An anti-inflammatory drug is a drug that reduces inflammation, and a drug that causes a loss of consciousness and or a complete loss of sensation, that is an anesthetic drug. So star. Underlying pain, inflammation, and fever is a substance that is produced in the body. And that substance is called a prostaglandin. So prostaglandins are unsaturated fatty acids, and they are released by tissues that have been injured. They're also released when your body reacts against an invading pathogen, like a bacteria, against certain toxins that are released by bacteria, or by substances that are released by white blood cells when you're fighting bacteria or viruses. So prostaglandins is the substance that triggers pain, inflammation, and fever within the body. So to understand how we can produce a drug that relieves pain, inflammation, and fever, we need to understand how this particular substance is produced. Prostaglandins are spelled Prostaglandins, prostaglandins. So prostaglandins are produced from the body from arachidonic acid, and we get that when we eat any proteins, especially animal proteins. We get arachidonic acid that's absorbed into our body, and our body changes that arachidonic acid into various types of prostaglandins, and we've got many different types, prostaglandin I2, E2, G, etc., etc. So for our purposes, we don't need to know specific prostaglandins. However, we do need to know that there are 2 main groups of prostaglandins that are produced by the body. So our body takes arachidonic acid, and using the COX-1 enzyme, it produces prostaglandins that are important just for general maintenance of our body. Specifically, they're important for platelets, so to produce blood clotting. They're important to maintain kidney function, and they're also important in order to maintain the lining that protects our stomach, so that mucus lining that protects it from acid. Prostaglandins are important in helping keep that lining healthy. A different enzyme, COX2, that enzyme produces prostaglandins that are important for the whole inflammatory response. So they are the prostaglandins that initiate pain, that cause heat in the area because they cause blood vessels to dilate and more blood moves to that area. They cause inflammation or swelling, so fluids that move out of those blood vessels into the surrounding tissue, and they initiate fever. So when we're looking at drugs in order to reduce things like pain, heat, inflammation, and fever, one way we can look at it is can we prevent the production of these specific prostaglandins? Okay, we're going to look at pain first, because pain is fairly complex, and it's also very important to understand the underlying cause of pain, and so that we can best support somebody and manage pain. So pain is an unpleasant sensory or emotional experience. It can be associated with actual tissue damage. So for example, if you hit yourself on something and it damages tissue, then that's going to produce pain. But it can also be associated with potential tissue damage. So for example, if you twist your wrist back to a certain point, you start to experience pain, even though tissues have not yet been damaged. But what your body is telling you is that if you continue with that action, then tissues will become damaged. So pain, on a very simple level, is a defense mechanism that helps us avoid damaging situations, and it encourages us to seek help or medical help, or to protect tissues that have been damaged. So pain itself is not a disorder, but it's a symptom of a disorder. And so if we really want to look at how do we get rid of pain entirely, how do we solve it or cure it, then we really need to look at what's the underlying cause and correct that. However, we can use drugs to manage that symptom and relieve that symptom on a temporary basis. And that's really what analgesic drugs are designed to do. It's important that we're able to classify pain. There are many different ways. In general, we can divide pain into either acute pain, so something that happens fairly suddenly. It's usually a very severe pain. It's very localized to one particular area. It's often sharp, so it feels like a sharp or stabbing type of pain. And it usually has a limited duration, so once that underlying cause is removed, then it goes away. Chronic pain is a type of pain that is very long-lasting or reoccurring, so by definition more than 6 months. Usually it's more of a dull, aching, annoying, constant type of pain as opposed to an acute situation. It's important to understand that pain can be initiated by our pain receptors that are located in our skin. And usually that's caused by direct injury to the tissues. Or pain could also occur if we activate the pain pathway, and we call that neuropathic pain. And that's usually injury to nerves, and that's usually a different type, more of a burning, shooting, or numbing type of pain, as opposed to the pain that comes from our pain receptors. Some other important concepts about pain is our pain threshold, which is the minimum amount of a stimulus that causes us to perceive pain. So remember that pain is subjective. It has both physiological components, because there's an actual substance that is reacting to tissue damage, but it also has a psychological component to it too, and which makes it subjective. So it's molded by the person's age. So in general, the older a person gets, the lower the pain threshold becomes. So it takes less and less of a stimulus before a person actually physically perceives that pain. Gender is a factor. So in females, they have a lower pain threshold. Ethnocultural background can affect pain threshold, personality, whether you've experienced pain previously, and in general, if you have experienced pain previously, that may either lower or raise your threshold. your anxiety level and the surrounding environment. So for example, if you are uncomfortable or if you are more anxious, then you're going to have a lower pain threshold. So this is important. This is a star, 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 because this means that without drugs, we could influence the perception of pain for an individual if we can raise their pain threshold. So for example, we know that a person's threshold can be lowered by anger, anxiety, depression, discomfort, fear, isolation, persistent pain, no sleep, fatigue, those types of things. So if we can eliminate those factors, then we can increase their pain threshold, and they will be experiencing less pain even without any analgesic drugs. So that's why it's so important to do things like be empathetic, to give the person rest, to try to produce diversion from that pain, to make them comfortable. They're not hungry, they're not cold, or too hot. Those types of things can go a long way in order to alleviate their pain, and we can use a lot less pharmacology. We can use a lot lower amounts of analgesic drugs to control that pain. When we are managing pain, particularly if we're going to administer analgesic drugs, it's important to be able to assess that pain, to know whether or not you need to administer an analgesic drug and how much you need to administer. So one of the things to look at is pain intensity. And we get a person, this is fairly subjective because they have to look at their own pain and then assign that pain a place on a scale. So you can use a numeric scale. So for example, 1 to 10, where 1 is no pain and 10 is the worst imaginable pain, and they rate their pain. And we can do that before we administer the drug, and we can also then have them assess or rate their pain intensity after we give the drug to know whether or not the drug is working. So for some people that are nonverbal, for example, or for kids and have a difficult time figuring out where their pain falls on a scale, we can use pictures. It's also important to get the person to express what their pain character is. So things like, when did this pain start? Where is it? What is the quality? Can they describe what it feels like? Is it burning, stabbing, throbbing, sharp, radiating, etc.? Also things like what makes it worse, what makes it better, how is it affecting their day-to-day activities. Now keep in mind that a person's pain threshold and how they perceive pain and their pain tolerance are all going to change even with that person from day to day. So there will be some days when they have a higher pain threshold and some days when they have a lower pain threshold. So when we look at managing and supporting a person that is experiencing pain, we have to take into account these subjective aspects of pain. So we have to take into account, have we used all of their tools that are available to us to increase their pain threshold and tolerance? So have we made them comfortable? Have we provided emotional support? Have we decreased their anxiety? Have we created diversions, and so on? The other thing we can do, as long as it's not contraindicated, is we can try some non-pharmacological interventions, things like acupuncture, biofeedback, massage, providing hot, heat or cold, meditation, imagery, hypnosis. There's all sorts of things that are out there that are non-drugs. And some of them work for some people and not for others. And so those are things that you need to try. You just want to make sure that you are not making a situation worse. So you have to make sure that it's not contraindicated. So when we need analgesic drugs is when considering those types of factors and trying those types of interventions don't work. In order to understand how analgesic drugs work, we have to understand what the pain pathway is. And so pain begins in our pain receptors, which are free nerve endings in the skin. And when they get stimulated, and they can be stimulated by a variety of chemicals, including prostaglandins. So prostaglandins will stimulate those pain receptors. The fancy way of saying pain receptors are nociceptors. So when they stimulate those nerve endings, then that electrical signal travels towards the central nervous system through a sensory nerve, and it synapses onto another neuron in the spinal cord, crosses to the other side, and then goes up the spinal cord to the brain. That signal gets relayed in the thalamus, and then it goes to various parts of the brain, including our somatosensory cortex. And so that's how our brain knows what part of our body is in pain. So not only do we know, yes, it's painful, but we also know where it's located. So if I hit my right hand, I know that's exactly where the pain's originating. It also goes to other places, like it goes to our hippocampus so that we remember it. It goes to our amygdala so we have some sort of emotion. It goes to our motor cortex so that we can, provide some sort of action. So it goes all the way around in the brain. So if we're going to create a drug to block this pathway, there are several places that we can block the pathway. Maybe we can block it right in the periphery at our pain receptors. Maybe we could block it in the spinal cord. Maybe we could block it in the brain. But that's what an analgesic drug does, is it blocks specifically that pain pathway. There are essentially two classes of analgesic drugs. There are analgesic drugs that are opioids or narcotic drugs, and there are ones that are not opioid or non-narcotic drugs. And the two of them work in different parts of the pain pathway. So non-opioid or non-narcotic analgesic drugs block the production of prostaglandins that are going to stimulate our pain receptors. Opioid and narcotic drugs, they block the pain pathway in the brain and the spinal cord, and what they do is they block opioid receptors. And we're going to talk about each of these. An adjuvant drug is something that isn't an analgesic drug. It doesn't block the pain pathway, but it will enhance the effect of an analgesic drug. So one type of non-opioid analgesic drug is a group of drugs called non-steroidal anti-inflammatory drugs, or NSAIDs, and they block the production of prostaglandins, and they do it right down here at the periphery so that prostaglandins are not produced, and so they don't stimulate those pain receptors. Prostaglandins are also part of the inflammatory response, and so as a result, NSAID drugs not only block pain pathways, but they also reduce inflammation. So they have both of those effects. We have two main classes of NSAID drugs. So originally, when they first discovered that they could block the production of prostaglandins, they produced drugs that blocked both COX-1 and COX-2 enzymes. And so they prevented the production of inflammatory prostaglandins, so that blocked pain, it reduced heat, it reduced inflammation, but they also blocked the other COX enzyme, COX-1, and as a result this created some side effects because some prostaglandins that were important for just our regular body maintenance were also being affected. So side effects to non-selective NSAID drugs include things like the inability to produce blood clots or reduced ability to produce blood clots. It may affect kidney function, and one of the main effects, is that if high doses are used for a long period of time, then the stomach lining becomes compromised, and so a person is more at risk for things like an ulcer. So it reduces the protection of the stomach. So NSAID drugs are used usually for temporary relief of mild to moderate pain. So this includes things like ibuprofen, acetylsalicylic acid, naproxen, indomethacin. I would like you to know those specific drug names, the ones that have asterisks here in it that are in purple. And again, important points that if they may, especially if they're used in large doses, or if you exceed the maximum dose, or if you use them for long periods of time, then the stomach lining can be damaged. It may worsen bleeding. Sometimes we use that as a therapeutic action. So for example, sometimes people will take acetylsalicylic acid or aspirin in small doses over a long time to prevent blood clots. One other thing I'd like you to make a note of, put a little star here, is that they may cause bronchospasm. So people that have asthma should be very careful when they're taking NSAID drugs. And they also may result in Reye's syndrome, which is why we usually don't give children acetylsalicylic acid or aspirin anymore. We use either Tylenol or we use ibuprofen to control pain. And this is because of Reye's syndrome. So this occurs if we use ASA specifically as a treatment of viral infections in kids, and it starts to affect brain and liver function. It's relatively rare now, but it was much more prevalent when we didn't have options like ibuprofen or acetaminophen. We also have drugs. More recently, they discovered a way that they could block the COX-2 enzyme only, and so therefore just block the production of inflammatory prostaglandins. And this was a big breakthrough because now, of course, we're not affecting all of our housekeeping prostaglandins, so we don't have those same side effects. So initially this was really celebrated, and this is great. So people that have arthritis, for example, could take higher doses and for longer periods of time and not worry about developing ulcers or having problems with kidney functions or platelets. However, there were some issues, especially in the early days, and even still there are some cautions. People that were taking COX-2 enzyme inhibitors, they had an increased risk of myocardial infarction or heart attack and stroke. And so now, and for a while, some of these COX-2 inhibitor drugs like Vioxx were taken off of the market. Celebrex at that time, which is the current example of this type of drug, they took theirs off the market also voluntarily, in order so that they could figure out what the underlying issues are. It's now back on the market, but certainly if you are taking COX-2 inhibitor drugs, you should be monitored by a family physician, and the family physician will ask about previous history of cardiovascular disease specifically, because there is an increased risk of heart attack and cardiovascular issues when taking these drugs. The last type of non-opioid analgesic drug that we'll talk about is acetaminophen. And acetaminophen is kind of in a class of its own. We don't really know how it works. We think that it blocks the production of prostaglandins, but not here in the periphery, but in the brain. Because it doesn't affect prostaglandin production in the periphery, then it will not reduce inflammation. So acetaminophen is an analgesic drug. It works up here in the brain, but it will not reduce peripheral inflammation. It's not an anti-inflammatory drug. Some important points that certainly we've known for a while, that overdose of acetaminophen can cause quite severe kidney and liver damage. More recently, we realized that this type of liver damage can occur very rapidly if it's taken with 3 or more alcohol drinks per day. And even after a weekend of drinking and taking acetaminophen can cause very sudden liver damage. And so there are big warnings that are now on Tylenol and other acetaminophen products. And for a while they wondered if they would take it out of an unscheduled drug category so that it couldn't be sold at Max Milk, that you'd have to buy it from the pharmacist. But I think they're going to try the warnings and public education route first. Because acetaminophen works up here in the brain, and other non-opioid analgesics like ibuprofen work down here in the periphery, you can take them at the same time. So if you have a fever or a pain that is very severe, you could take a dose of Tylenol at the same time as taking a dose of ibuprofen, and sometimes that works to, to cut down pain. Okay, we're going to take a break here, and I'll come back with the second part.